All right, let's keep working with the idea of veins. We're going to bring in gravity, our old friend gravity. Hopefully you remember, just like it was yesterday, that pressure at the bottom of the column equal height times gravity times density. Well, we stand upright, so that creates a column. So as we move down from the heart, pressure increases because of gravity. We're in the upright position. All right, if pressure is going up, that's going to cause veins to distend because they're very compliant. The term we use for this is venous pooling. So standing upright is going to result in venous pooling. So blood is going to pool in the veins. Well, remember, if it's in the veins, then it's not in the heart. It's not in the heart. So this venous pooling will decrease volume in the heart. And if I reduce volume available for the heart to pump, then I reduce the ejection. That's Frank Starling. If the heart don't get it, the heart don't pump it. Now, if stroke volume is going to fall, that means cardiac output is going to fall, which means mean arterial pressure is going to fall. And if I don't compensate, mean arterial pressure will fall too much, and the brain will say, forget it, turning out the lights, and you pass out. That's called syncope. So that is the threat. The threat of standing upright brings into play gravity, and the threat is a reduced venous return because the veins are now holding more blood, venous pooling. So we have to be able to deal with it. We must compensate or else blood pressure will fall. All right, how do we deal with this stress? We have sensors. And the main sensors to the threat, to an orthostatic challenge, that is the term for standing upright, are cardiopulmonary mechanoreceptors, also called cardiopulmonary baroreceptors. These are stretch receptors in the heart, in the great veins, and the pulmonary artery. So they're on that low pressure, high volume side of the circulation. Okay? Again, they're called cardiopulmonary mechanoreceptors, but you may see the term cardiopulmonary baroreceptors. Now, afferents, these are stretch receptors. They're mechanoreceptors. So afferent activity is directly related to the volume of blood in the heart. So effectively, they're responding to changes in preload. Now think about the setup here. We have stretch receptors in and around the heart. So if volume goes down, there's less stretch. If volume goes up, there's more stretch. So effectively, we have these receptors monitoring the volume of blood available for the heart to pump. Because the body knows, Frank Starling, if the heart don't get it, the heart don't pump it. I need to warn the brain. So if preload goes up, if I increase venous return, we will activate these receptors. Now, if I activate these receptors, here's the thing to key on. What do? Stimulation of the receptors stimulates parasympathetic and inhibits sympathetic. Just lock on that. That's what you have to know. Stimulation of these receptors stimulates parasympathetic and inhibits sympathetic. So I'm going to turn on the vagus and turn off the sympathetics. Now, hopefully you're already thinking of the ramifications of that, but we will go through it. Now, these receptors also inhibit the release of ADH. Chapter 1, we talk a little bit about ADH, but then later in the section on endocrinology, this will come in again. And these receptors are big influences on ADH. Now, let's go the other way. If preload falls, in other words, the blood in the heart falls, there's less stretch. That means less activity of these receptors. So, as a result, parasympathetic activity goes down and sympathetic goes up. So in other words, we are disinhibiting the sympathetics. By reducing this activity, sympathetics go up. And since we have less activity, we have less stimulation of parasympathetics. So therefore, parasympathetic activity goes down. All right, let's see if this reflex makes sense. this cardiopulmonary response. Now, if volume in the blood in the heart goes down, like when we stand upright because of venous pooling, these receptors are going to fire less. So we'll have less afferent input. Well, that's a signal to the brain. Look out, beware. Frank Starling on board. Frank Starling's coming. All right, and it's a down Frank Starling, not an up Frank Starling. We have reduced volume. So get ready. And also think about this. These receptors are on the right side of the circulation, where venous return is occurring. There's a little bit of time delay before a decrease in venous return to the right heart significantly affects the left heart. So we have a little time. Let's trigger a nervous response. So when volume goes down, we activate the sympathetics. This is going to cause arteriolar vasoconstriction. So TPR is going to go up. Well, again, the threat is we know cardiac output's going to fall. I want to keep blood pressure constant, so I'm going to constrict arterioles to increase TPR to try to keep blood pressure from falling. Hopefully that makes perfect sense. Remember that sympathetics are releasing norepinephrine. This is an alpha-mediated vasoconstriction. Because I'm going to have less parasympathetic and more sympathetic, heart rate's going to go up. Well, hopefully that makes sense. We know stroke volume is going to fall, so let's try to counter that with an increase in heart rate, so maybe cardiac output doesn't fall as much. We will also venoconstrict. Sympathetics cause alpha-mediated venoconstriction. The idea is let's try to squeeze on these veins that are holding this blood. Because I have venous pooling. I mean, that's my initial insult. So those are going to be the responses associated with the sympathetics to try to maintain mean arterial pressure. Remember, the goal is to maintain mean arterial pressure to perfuse the organs of the body. Now, if these can't kick in quick enough and keep mean arterial pressure constant, so in other words, if mean arterial pressure falls, then arterial baroreceptors will kick in. And maybe mean arterial pressure falls a little, but remember, cardiopulmonary receptors are your first line of defense. In a perfect world, they would signal the nervous system, they would turn on the sympathetics enough that even though I have reduced venous return, I engage all these responses, and so mean arterial pressure doesn't change. All right, going back to our basic picture, again, stand upright, pressure goes up, we get venous pooling because they distend. This reduces volume in the heart. We kick in the cardiopulmonary mechanoreceptor reflex. Less volume in there turns on sympathetics. We're going to vasoconstrict, venoconstrict, and make heart rate go up a little, with the idea being mean arterial pressure doesn't change. So the threat, the initial threat is a reduction in venous return. All right, let's integrate a little path and a little form. The initial stress, the initial threat is a reduced venous return. So hopefully now we can think about, well, what kind of conditions are going to create orthostatic intolerance? And orthostatic intolerance means people who get lightheaded or may go to a full-blown syncope when they stand upright. This orthostatic challenge is just a little bit too much. All right, the initial threat is venous return. It's a drop in venous return. So hopefully you're thinking, okay, anything that compromises venous return in a person is going to make them more susceptible to orthostatic intolerance. Did you say blood volume? I sure hope so. Remember, blood volume goes down, PSF goes down, venous return goes down. So loss of blood volume should be one of the first things that jumps into your head if you get a clinical vignette related to orthostatic intolerance. May not be the correct answer, but it's certainly on your differential. It's a big player. So anything that compromises vascular volume will make somebody susceptible to orthostatic intolerance, like diarrhea or vomiting. Clinical vignette. Patient X comes in after 4 days of vomiting. Odds are they're going to have orthostatic intolerance. Next, well, anybody on venodilators or alpha blockers. And it turns out the venodilators are much more likely to cause orthostatic intolerance than just straight up alpha blockers. But either one potentially. But a venodilator, I can't constrict the veins, so I don't get that sympathetic venoconstriction to help. Yep, it's going to cause orthostatic intolerance. Also, patients who don't have cardiopulmonary reflux. Well, what patients wouldn't have a cardiopulmonary reflux? Somebody who's just had a heart transplant. The heart is denervated. It's not connected to the central nervous system. So they tend to have orthostatic intolerance. Also, people who have problems increasing cardiac function, like a congestive heart failure patient, they could most certainly develop orthostatic intolerance. And then last but not least, the dysautonomias. If I have a problem with my autonomic nervous system, then I'm going to have great difficulty dealing with the stress of standing upright. So dysautonomias are certainly associated with orthostatic intolerance. And remember, one of the things that can cause dysautonomias, diabetes mellitus. So that's what happens when we look below the heart. Now let's think about above the heart. All right, above the level of the heart, pressure is becoming less. We're going against gravity. Now that occurs on both sides of the circulation, just as it did below, it will above. So arterial pressure will go down. Also venous pressure will go down. Now remember, venous pressure at the heart level is pretty close to zero. So therefore, in the veins above the heart, venous pressure can become subatmospheric, or in other words, negative. When we reference pressure to being zero, then we have a negative intravascular pressure. Now, surface veins above the heart, they can't maintain a significant negative pressure and can collapse. However, the deep veins and those inside the cranium, they're supported by tissue and they can withstand a pretty reasonably significant below atmospheric pressure. They'll be able to keep those open, but the more surface veins won't be able to withstand this and can collapse. Now, big clinical consequence of that is that if I sever or puncture a vein above the heart level and I have a subatmospheric or negative venous pressure, then air is going to rush into the system. Remember, if you got a pressure gradient, if you have a pressure gradient, boom, air will flow. So now if I open a subatmospheric pressure vein, air comes right in, which is not a good thing. We can get emboli. That's clearly not a good thing. Okay, now we're going to talk about arterial pressure. We talked about the veins and their function and venous pressure and gravity, etc. Now what we want to do is talk about the arterial side of the circulation. There are 4 different ways we can talk about arterial pressure. There is systolic, that's the highest pressure in the system, that's when the heart is contracting. Diastolic, when the heart is relaxing. Mean arterial pressure, which is a time-weighted average. And pulse pressure, which is systolic minus diastolic. We'll start first with the factors, and for USMLE Step 1, we need to think about the factors that influence each of these pressures. So we'll start first with systolic blood pressure. One of the big things that's going to influence systolic blood pressure is stroke volume. It is directly related. Stop and think about it. Pressure, volume, directly related. So if I pump more blood into the systemic circulation, greater stroke volume, then I'll get a higher systolic blood pressure. If I pump less blood into the arterial tree, less stroke volume, then I'll have a lower systolic blood pressure. So systolic blood pressure will be directly related to stroke volume. Second player is contractility. And again, directly related. Now stop and think about this. Hopefully it makes sense. If I contract the heart with more force, increased contractility, then I will generate a greater systolic blood pressure. If contractility falls, then I'll have a lower systolic blood pressure. So again, directly related. Last but not least will be arterial compliance. Now remember, when we talked about the whole circulation, the entire circulation, the compliance, most of the compliance, the vast majority of the compliance, is on the venous side. Now what we're talking about is arterial compliance. And there will be an inverse relationship between systolic blood pressure and arterial compliance. In other words, let's say the aorta becomes stiffer, less compliant. So it won't expand when we get ejection. It won't expand as much when we get ejection. So if I try to put the same volume in a container that doesn't expand very much, then the pressure is going to go higher, inversely related. On the other side of the coin, if I have a very compliant aorta, it will expand when it gets that pressure wave, when it gets that volume ejected into it. It will expand out, and thus the pressure will be less. So again, inversely related. If compliance goes down, then systolic blood pressure goes up. If compliance goes up, then systolic blood pressure goes down. So those are going to be our key factors influencing systolic blood pressure. Stroke volume, contractility on a beat-to-beat basis will be the most important. Long-term, arterial compliance will be a huge player. Okay, that was systolic blood pressure. Now let's talk about diastolic blood pressure. There's a sentence in your book. Go ahead and highlight it because that is the key. Diastolic blood pressure is directly related to the volume of blood in the aorta at the end of diastole. Again, diastolic blood pressure is directly related to the volume of blood left in the aorta at the end of diastole. Diastole is when the heart's relaxing, and what we're getting is what's called diastolic runoff. So in other words, that blood that got ejected into the aorta during systole is now leaving the aorta and going to the various tissues of the body. So ultimately, diastolic blood pressure will be directly related to that volume of blood left in the aorta at the end of diastole. So the factors that are going to influence it, the first will be total peripheral resistance, and it's directly related. Now, if we think about this, if resistance falls, then more blood can leave the aorta in diastole to go to the tissue because there's less resistance. With less resistance, we get a greater flow. So, a greater diastolic runoff. Since more blood has left, diastolic blood pressure goes down. On the converse, if TPR goes up, it's more difficult for the blood to leave the aorta, so we get less diastolic runoff, and as a result, diastolic blood pressure goes up. So TPR, a big player in influencing diastolic blood pressure, and it is directly related. The second is heart rate. Now, if we think about this for a second, remember that the time in diastole is influenced by heart rate. So diastolic blood pressure will be directly related to the heart rate. If heart rate goes down, we spend more time in diastole, and as a result, we get a greater diastolic runoff. So if heart rate falls, then diastolic blood pressure falls. If heart rate goes up, we spend less time in diastole. As a result, we'll get less diastolic runoff, and diastolic blood pressure will go up. So heart rate, will influence diastolic blood pressure, and they are directly related. TPR and heart rate are two biggest players influencing diastolic blood pressure. The final one is stroke volume, and it is directly related. Remember, stroke volume also influenced and was a big player in influencing systolic blood pressure. And again, it was directly related to systolic. So, if stroke volume falls, systolic falls, diastolic falls, and will have a bigger impact on systolic than diastolic. The two big factors, as I indicated, for diastolic are TPR and heart rate. Stroke volume does play a role, but it's a much more minor role. The next way to talk about arterial blood pressure is pulse pressure. And again, pulse pressure is systolic minus diastolic. In this example, systolic's 120, diastolic's 80, so the pulse pressure is 40. Now I'm going to go back to my base concept equation. The change in pressure is equal to the change in volume over compliance. This will show us the two players influencing pulse pressure. If we think about this, pulse pressure is the change in pressure per beat. So I can just change the delta P, change in pressure, to pulse pressure. Now the change in volume to the systemic circulation per beat is stroke volume. So now I have my two players influencing pulse pressure. It is directly related to stroke volume and inversely related to compliance. And remember, this compliance means the arterial tree, not the circulation as a whole. Now, important construct that we can work with is that stroke volume, of course, can change acutely and chronically. There's usually not a very significant change in compliance of the arterial tree acutely. May change a little bit, but by and large, we can ignore that idea. Now, here's something we can take advantage of, a very quick analysis. Notice, pulse pressure is directly proportional to stroke volume. So if you have a patient, or you get a clinical vignette on step 1, and the person's pulse pressure changes acutely, then you know their stroke volume changed. For example, patient has a blood pressure of 120 over 80. 10 minutes later, blood pressure is 110 over 90. Well, pulse pressure went from 40 to 20. You know immediately stroke volume went down. Not a lot of calculation, just very basic calculation. And we can come to a very, very important conclusion. That big drop in pulse pressure is telling us that the patient had a big drop in stroke volume. Now what we have to do is figure out why. Is it a contractility problem? Is it a volume problem? Frank Starling? That wouldn't be an afterload problem, because 120 over 80 to 110 over 90 doesn't suggest a big change in TPR necessarily, so it's not really an afterload problem. More likely, they either have lost blood or the heart is not ejecting well, say myocardial ischemia. So take full advantage of this idea. Very quick analysis and interpretation. Again, an acute change in pulse pressure is telling you a change in stroke volume. Now, we can't compare one person to another person, their pulse pressures, and conclude stroke volume. And that's because of the other player, compliance. For example, if compliance goes down, then pulse pressure goes up. And we'll see an example of that on the next slide. Notice the two different pulse pressures. The one on the left is representative of the aorta, whereas the one on the right is more representative of a large artery like the femoral artery. Compliance is less in the large arteries than it is in the aorta. For the arterial tree, the aorta typically has far and away the highest compliance. So notice the small pulse pressure in the aorta compared to the peripheral vessel, the femoral artery. and that's because compliance is less. Now, the physicists, of course, would talk about pulse wave reflection, etc., which is probably technically correct. But for USMLE Step 1, the key to think about is compliance and pulse pressure, and realizing that an artery like a femoral artery is less compliant than the aorta, and that's why pulse pressure goes up. Now, a big construct for Step 1 is the following idea. As we age, the compliance of the arterial tree goes down. So what we expect in the aging population is an increase in pulse pressure. And that's typically what is seen. And then, of course, we do have to worry about the idea of systolic hypertension. But it's not uncommon, particularly people in their 80s or 90s, to have pretty big pulse pressures indicating a stiff, non-compliant arterial tree. The fourth way we talk about arterial blood pressure is mean arterial pressure. This is a pressure averaged over time. In other words, a time-weighted average. Now, there's two different formulas that you can use. Here's the first. Mean pressure is diastolic plus 1/3 the pulse. Or you could do 2/3 diastolic plus 1/3 systolic. Either one are going to get you to the exact same answer. I personally use the first one because I find that most of the time I can deal with the numbers in my head. All I have to do is have 1/3 the pulse pressure. That's the only calculation I have to make. If you prefer the second one, then most assuredly use the second one. Let's use an example. Classic textbook arterial blood pressure, 120/80. Now, the way I typically do it is 1/3 the pulse plus diastolic. Well, I know 120/80 has a pulse of 40. 1/3 of 40 is 13, so 80 plus 13 gives me 93. Using the other formula, you will get to the exact same point. But again, I like the first one because I only have to do one calculation where I'm taking a third, rather than a calculation where I do a third and a calculation where I do 2/3. But if you like the second one, most assuredly use it. Do what works for you. Don't forget, mean arterial pressure is our pressure head driving flow to the body. So it is very, very important that we maintain an adequate mean arterial pressure. We'll talk about the baroreceptors and their role in maintaining arterial blood pressure in just a moment. All right, what's going to influence mean arterial pressure? Well, it's our pressure flow resistance. Pressure flow resistance. Mean arterial pressure equal cardiac output times TPR. That's just an expansion of our basic pressure flow resistance relationship, utilizing whole body aspects. So very, very powerful relationship to know for USMLE Step 1. So the two variables that are going to determine mean arterial pressure are, of course, cardiac output and TPR. Cardiac output is that circulating volume. Don't forget that if it's stored in the veins, so if it's stuck in the veins, venous pooling, like with gravity, or in a pulmonary circuit, this wouldn't be part of the cardiac output. Remember, those veins are very, very compliant. TPR represents the resistance of the vessels in the systemic circulation. We talked about that earlier. The big player here, arterioles. Arterioles are the main site of resistance. Now, that mean arterial pressure equal cardiac output times TPR is not a technically correct equation, but it's a great relationship to remember to think about regulation of mean arterial pressure. And we can just usually drop the right atrial pressure because it's not usually very high. However, it must be taken into account if I want to estimate TPR, particularly if right atrial pressure is severely increased. So the technical formula is mean arterial pressure minus right atrial equal cardiac output times TPR. Again, we just dropped the right atrial pressure because it's usually pretty low, and we work with the relationship to think about cardiovascular regulation. But if I really need to calculate a TPR, I do need to take into account right atrial pressure. So TPR is mean arterial pressure minus right atrial divided by cardiac output. Okay, as I alluded to earlier, baroreceptors. Baroreceptors are our short-term regulator of arterial blood pressure. That is their job. Arterial baroreceptors regulate. They try to maintain mean arterial pressure constant. The RAS system, renin-angiotensin-aldosterone system, that's our long-term regulation of blood pressure because we're regulating the blood volume. So for now, let's talk about this baroreceptor reflex. All right, let's talk about those arterial baroreceptors and the baroreflex. Baroreceptors are mechanoreceptors, and these receptors are embedded in the wall of the vasculature in the carotid sinus and in the arch of the aorta. These baroreceptors, mechanoreceptors, the nerve afferents send their signal to the brain, two different nerves. Cranial nerve 9, do you recall what that is? Yes, glossopharyngeal, very good. Cranial nerve 10? Correct. That is the vagus. Excellent. So we're going to send this signal from baroreceptors to the medulla. The medulla is our site of integration for parasympathetic and sympathetic. This is a very powerful short-term regulator of arterial blood pressure. All right, here's the key. This is what we focus on. Mechanoreceptors, remember, are stimulated by stretch. So the more stretch, the more activation of arterial baroreceptors. What does their stimulation cause? An increased parasympathetic and a decreased sympathetic. That's what we focus in on. That's what we need to remember. Because now we can just apply our knowledge of what parasympathetics do to the cardiovascular system and what sympathetics do to the cardiovascular system. Remember, parasympathetics innervate the heart, releasing acetylcholine. Do we recall the receptor? If you said M2, very good, very good. In which they're going to decrease heart rate, that's SA node, and decrease conduction velocity through the AV node. So when I stimulate parasympathetics, heart rate's going to go down, which will tend to drive down cardiac output and drive down blood pressure. So parasympathetics are working to decrease mean arterial pressure. Sympathetics, on the other hand, increase heart rate, increase contractility, increase conduction velocity. They reduce the systolic interval. Hopefully you remember that in our discussion of the mechanics of the heart. And that receptor is, do you recall that receptor? Excellent. If you said beta 1, very good. And don't forget, beta is our original camper. Beta 1 is GS cyclic AMP. By increasing heart rate and increasing contractility, we're tending to drive up cardiac output to increase blood pressure. We also get venoconstriction. And hopefully you remember what that means. That means reduced venous compliance to increase venous return, and as a result, increase cardiac output. So sympathetics are working to drive up cardiac output. In addition, sympathetics stimulate what receptor on arterioles? Excellent, alpha-1 receptors, and that's the GQ pathway. Stimulating sympathetics causes an alpha-mediated vasoconstriction to increase TPR. So, sympathetics are driving up both cardiac output and TPR to drive up mean arterial pressure. Now, this is a negative feedback loop. Again, all we have to remember is what baroreceptors do. They stimulate parasympathetics and decrease sympathetic. So if blood pressure goes up, there's more activation of these receptors, which is going to stimulate parasympathetic and inhibit sympathetic. By stimulating parasympathetic and inhibiting sympathetic, I'm tending to bring blood pressure back to its original level. Now, these baroreceptors are active at arresting blood pressure, and that's crucial, because if arterial blood pressure falls, that means less activity of baroreceptors, which means less parasympathetic stimulation, so parasympathetic is going to go down, and less inhibition of the sympathetic, so bottom line, sympathetics go up. So if blood pressure falls, we get less stretch. This is going to activate the sympathetic nervous system and drive down the parasympathetic nervous system, both of which are going to tend to drive up cardiac output and TPR in order to bring blood pressure back. Negative feedback, and a very powerful negative feedback loop. It's the baroreceptor's job to maintain mean arterial pressure. They're going to ask you a lot of questions about pharmacology and autonomic drugs. For example, if you give an alpha agonist, that's going to drive blood pressure up. You need to know immediately the idea of the baroreflex. By giving an alpha agonist, increasing TPR, increasing mean arterial pressure, heart rate's going to go down. And heart rate's going to go down in large part because of the increase in parasympathetic activity. On the converse, if we vasodilate the periphery, alpha blocker, we're going to get a tachycardia. This baroreflex, very powerful, very important to know for step 1. Know what happens to that heart rate particularly. Okay, this is kind of a scary slide. Look at all the arrows. Oh my goodness, please, please tell me you're not going to try to memorize this for step 1. You go in on the exam and you just have this memorized, you don't understand it, and you will get your arrows turned around. So let's not do that. Here's what we focus in on, what we already discussed. Okay, blood pressure goes up, we stimulate baroreceptors, parasympathetic goes up, sympathetic goes down. Blood pressure falls, less afferent activity. That means parasympathetics go down, sympathetics go up. And we just figure everything else after that. We don't try to memorize this. These tables are good for thinking through processes, though. So I do encourage you to work with them, but perhaps cover up all the arrows and figure it out yourself. Let's just do 1 or 2 just to kind of work through it. All right, let's occlude the carotid arteries. Now, remember, carotid sinus is downstream from the main carotid artery. So if I occlude, that means resistance went up. So can you remember what happens to downstream pressure? Yeah, excellent. Downstream pressure goes down. So when I occlude the carotid artery, I know downstream pressure, carotid sinus, downstream pressure, carotid sinus, is going to go down, which means the baroreceptors are going to turn on sympathetic and drive down parasympathetic. So I'm expecting a rise in TPR and a rise in cardiac output. I'm expecting tachycardia. Okay, we don't need to be looking at all the arrows. Just cover them up and walk your way through. If I massage the carotids, okay, you do a carotid massage, that's like stimulating baroreceptors. So I know immediately parasympathetic activity is going to go up, sympathetic is going to go down. So I'm expecting a drop in heart rate and a drop in TPR. So I highly encourage you to work with these ideas, but please, please don't memorize this. Don't memorize it. We're not here to memorize. Okay, we're here to understand. You should be able to generate this table all day long with just remembering the basic aspects of what baroreceptors do, which I have highlighted in pink that we discussed on the previous slide. So think your way through. All right, I mentioned the carotid massage on the previous slide, and that rolls into the idea of a clinical correlate. One of the ways to increase vagal outflow to the heart, and you may want to do that when somebody has a supraventricular tachycardia. to try to drive that heart rate down by stimulating vagus to the heart. Carotid massage is one maneuver that can increase vagal outflow to the heart and can be helpful in somebody with a supraventricular tachycardia.